I'm happy to answer any questions. Now, diploma's got about 12 modules, and you know, a lot of the dentists want to know about full mouth reconstructions, and I'm saying that before we get there, there's you got to go through all these modules. But also to help the practitioners in their practices, we're actually going to give, like doing lots of courses where we talk about when to choose porcelain or composite veneers in your practice, what's the importance. This will be an online course. The dates are not confirmed yet, but if you're interested, please let us know. Just register with Shraddha or send us an email. We're happy to start put you in. This is a very popular course, I believe. I mean, this is a porcelain here, and this one's a composite. And I think we've done a video for this video.
By Ronnie and Georgia are feeling the pressure.
Okay, and then you got piezo surgery. Stan, you probably love this part where we talk about how to incorporate piezo surgery down in practice. This is a it's not, the dates are incorrect, that's why they read, I apologize. So it's all about how to incorporate this not only in your daily practice, but also in your restorative practice. We're doing fine marginal preparations, and your hand pieces sometimes, if that fine area is damaging to the tissue, so piezo surgery marginal preparation is very good from the periodontal and the restorative point of view. It allows your tissues to heal faster. So there's a lot of things that we bring to the course, and you know, this is not part of the course, it's a separate course. This is a 2-day course. And then we've got solving problems with using composites, trauma cases, patient comes in surgery with trauma. What would you do? How do you get the patient from A to B in one visit, making a sound? And complex reconstructive cases, how do you make things simple? Why do you don't have to do all this full mouth crown bridge, where you can actually do it in a very simple way. And we got over a lot of these cases. We have over 12-year studies on these cases, people maintaining simple, you know, simple treatment, simple and effective treatment for these patients. And then we also have tooth wear, and we gave this course last time, but it's more refined. We do the course in my practice here, and this is a very popular course. It's changed many ways, and we're going to talk about how do we get the patient here to there, minimal intervention, and these people are very happy. I mean, you know, they're happy showing their pictures before and after. I mean, that's what it's all about. They're happy. And this is a tooth wear before and after. This is composite veneers on here. So it's all coming in. The next course we have is just to give you, we have over 30 courses that are coming in. So, you know, the online course will be the all diagnosis of trivial tooth wear, minimum intervention, composite rehabilitation, the FRC 5 on the bridge work, 10 commandments in aesthetic dentistry, with 2 that with prosthesis and alternate interface, and part 1, part 2, TMD, part 1, part 2. Well, piezo surgery is already there, and we got an icon course. And loads other things. How do we think? What to do? That's all little things. Like I talk about little things, single cases. So we're putting those courses soon online, and there'll be hands-on components as a separate course to what the core diploma is and certificate. So we're coming to our course now. This is the case that me and Stan have treated together, and Dr. Howard has also been part of it. She did the orthodontic part of this work. As a matter of fact, Dr. Howard was the one to refer this patient to me, and I'm going to invite Dr. Howard, Stan, also to come and say a few words when her part computers. But nevertheless, I think this case signifies and probably will challenge the paradigm of a lot of dentists in terms of what do we expect from treatments. In other words, you know, this patient is about 34, 35 years of age, and she presented to Dr. Howard's practice, and Dr. Howard, I mean, she asked for my opinion, and we just have a look here. So we know about this. We know how this works. We understand that, you know, she's in her 30s and dentistry is failing. And one reason that dentistry was failing for this patient was the fact that I asked the question, she was petrified dentist. So she goes to the dentist, and dentist, rather than understanding this patient from an emotional point of view, and puts her in a chair, asks her to open her mouth while she's lying in a reclined position, blasts the crap out of her, saying, you know, you're going to lose your teeth, you're going to do this. So people panic, rather than having a very objective way of explaining that, yes, we're going to try to maintain teeth. You have a high risk of bone loss and possibly tooth loss. And, you know, she's got a fremitus between 1.1 and 4.1. and the teeth are migrating. You can see there's a lot of attachment loss and gum recessions. And we call this recession of Miller's type 3, Miller's classification back in 1981, if I'm correct, Stan.
Yep.
And so, you know, more or less these teeth are mobile, and the chart will show. So well, let me ask the question to my colleagues. What do you see? Please just come into the equation. You know, there's no incorrect answer. I want to get a dialogue going with everyone here, please. What do you see? Okay, Nimesh, you speak.
Yes, we can see, of course, perio, exposed roots, discolored, of course, not discolored, but of course, the nicely done gold fillings on those premolars. And of course, considering the age of the patient, everything is an issue. I mean, where do we go from there? She is in a stage where probably some dentists might say it's a full series extraction and upper and lower full arch case, you know. But then we'll have to rethink and see, she's only 34, where do we want to go? You know, so first one, I'll probably just look at the perio. I haven't looked at the OPG, of course. So what's the level of bone loss? See where to go from here. I mean, we have to do the stabilize first and then take it from there. But I think, first of all, before we go into the treatment side of things, of course, understanding what's the situation is and what's the patient expectation are, because he's got a high smile, as I think we just shared a picture. So everything is on a display here. So very, very difficult case. Yeah.
You see, I've chose my cases very carefully and chose my images very carefully, Nimesh, as you know, because I chose it for a reason. And let's argument's sake, if one had to consider full mouth rehabilitation, she's been offered that in the past as well. The complication of that will be immense, and I'll prove that with time. I'll prove that with time.
Dr. Sarkis, there are two comments: bone loss and overbite.
Yes,
from
please.
Jesse.
Okay, Jesse, what was the question? Can you say that again, please? I'm just having a look here.
There are two comments: bone loss and overbite.
Okay, okay. Jesse, thank you for that comment. Can I ask a question in terms of, do you feel overbite has any relation to bone loss? Jesse, can you tell me? Or you maybe cause of recession? Okay, interesting. All right. Okay, Jesse. So in this case, have you? Okay. Jesse, let me help you that the recession overbite happens in traumatic occlusion, possibly. Is that right, Stan? Would you agree on that? That'd be where, and especially when you have a high phenum and there's a traumatic occlusion, especially on the palatal side, but I'm not aware of the labial side unless you have a severe class 2 and D2 situation with 110% overbite, and that's a possibility. Would that be correct? In class 2 D1 palatal and class 2 D2 labial, Stan, would that be on
the lower anteriors? Yes.
Yes, yes. And do you feel in this case we have that situation? Okay. Now, missing lower molars and majorly tilting second molars. Okay. Fine. And okay, do you feel there's an occlusal collapse? There's a posterior occlusal collapse here. Okay. Let me put you in a scenario. It is a traumatic occlusion. There's no question about that. But is this a primary occlusal trauma or a secondary occlusal trauma? Can anyone explain that to me? And what's a primary occlusal trauma and what's a secondary occlusal trauma? Can you give me some idea? please. Isidora? What's a primary occlusal trauma? Anyone? Okay, what's a traumatic occlusion? No one? Okay. I need some answer from the audience. So I'm going to call names, and I will call names. And I think it's good that everyone comes into it. Would you like to call names, or please have a chat to me?
Jesse says excessive force.
Excessive force, right. Okay, excessive force on the whole dentition or one dentition. How do you know it's a occlusal trauma? What's an occlusal trauma? You tell your patient there's occlusal trauma and there's a fremitus between 1-1 and 4-1. And the patient is presented with loss of attachment. No one mentioned calculi here, that's supragingival calculi. If I see this calculi here, what else am I thinking? Just from diagnostic, but what else am I thinking? I mean, Stan, sorry, I haven't brought you the equation yet.
No.
Ask the question. I mean, what's happening is that Stan, dentists look at the bite usually before they look at anything else. And that's part of the training they've been given. I mean, to me, I look at the whole thing as one, but we'd like to break it down. We talked about the bite. Jesse talked about the bite. That's very good. And Isidora talked about tilting second molars. I also understand that. But if you had to look at this patient, what would be number one thing that we would do in this patient in terms of trying to explain her condition? Remember, she's very apprehensive. She thinks she's going to lose her teeth. She's been told she's going to lose her teeth. And she looks in the eyes to say that, can you find some other solution for me? What would you say to the patient here? How would you explain the patient the condition? Okay, I'm gonna pick Joanna Tseng. How about you come into it, buddy?
Sorry, what's the question? How is it a traumatic
The question is,
occlusion?
what do you see? What do you see? And how would you explain to the patient who's very apprehensive about the condition who's just arrived to your practice?
You tell them the facts.
Such as?
There's a traumatic occlusion because there's a lot of wear, perio, loss of attachment, and aesthetically, it doesn't look quite pleasing as well.
She knows that, but how would you explain in terms of patient's language?
Well, there's
Yep.
there's a problem with the way she looks. The teeth are not looking great, and either we can try to fix it or we're going to find a solution, going to find a course.
Okay, all right. Thank you, Joanna. Thank you. I understand what you're saying. Is there anyone else wants to contribute to patient explaining? I mean, Michael Travishaw wants OPG, please, but at the moment, Michael, OPG will come into. We have the OPG for you, but let me ask you a question. Assuming the OPG is what you observe to be, okay, you expect some bone loss, and the patient's got fremitus between 1-1 and 4-1, and she finds it painful and chewing, and she's come to you for a solution. What would your first thing to do when you explain to the patient about this case? How would you try to put the patient at ease, especially when I initially said that the patient has been absolutely frightened from a dentist who say you can lose your teeth. They come to your practice and they want you to just be empathetic. How would you explain that to the patient? Can you see my angle the way I'm approaching this case? I want you to think like doctors. I want you to think like carpenters or mechanics. I want you to think like doctors. Okay, this patient's petrified of dentists. So I would say to the patient, I will take the X-rays, fine, and I will explain to the patient, look, let's just see if I can, I'm just going to go to the X-ray, refer the patient, stand, just come back to the stand. I'll send the patient to you, but before I send the patient to you, I'll say to Stan, well, I was hoping someone would say number of issues here. Is a patient a smoker? Is a history of smoking? What's the patient's health? At age 34, there's a lot of bone loss. What's the reason? There's neglect? Yes. I want to talk about the medical history, the dental history, their oral hygiene history. There's a poor oral hygiene. There's a lot of things are associated with it. So when talking to your patients, I would say to this patient, her name is Aileen, by the way. She was here. She's happy to show her face on issue. She came yesterday, especially so I can take images, not images, take a OPG and do the final period chart. I would say, look, Aileen, understand those upper and lower front teeth have got guarded prognosis, but I'm not going to be in a position to remove any teeth. I don't want to. I want to hang on what I have. You're age 34. And the fact that she has a high gum line, if you lose those teeth, you're going to have a massive bone loss, which you have, a massive gum recession. And placing implants and fixing aesthetically is a nightmare, because I understand that. Unfortunately, I see these patients already having their teeth removed when they turn up my practice, then the nightmare starts already. But then I will say to her, what I'm going to do is, I said, we might just give you a very gentle clean and get it comfortable. And I'll say, I'm going to refer you to periodontist. So I write to Stan and I ask them that Dr. Howard's hygienist has done initial clean. Patient's hard gums, gummy smile, good facial aesthetics. There's a hard and soft tissue loss, and we might be losing 1-1 and 4-1. I'm not quite sure. So would you carry out your assessment and treatment and provide me a follow-up to Dr. Stan? Individual tooth prognosis, oral periodontal stability. Can early orthodontic leveling align with once periodontal stability is achieved using light and control forces with TAS and posterior occlusal stability? Consensual implants support dental single modern tooth replacement. And is a motivator to have a treatment done, improve dental health, comfort, functional aesthetics. So the question I want to explain that it's about comfort, function, and aesthetics. So don't just stick to one thing. Stan, stage is yours. Please go ahead.
When referred, surprisingly, the probing disc, she's had a lot of recession. So you're looking at force attachment loss, you're looking at 7 millimeters. The main thing is the mobility that you've got around those upper incisors, right? There's fremators there. That's something that you have to sort of address. So basically what we did, we just put her through a course of debridement under local anesthetic, tried to improve her hygiene, and then we reassessed her again in 2 months. There has been improvement, probing depths, we're getting down, still 4s. Mobility is still almost the same. We've had very little reduction in mobility. If it's due to an inflammatory response, you expect to get some improvement. So until you correct that fremators as well, you're not going to.
So patient returned to me and I corrected the fremators, and then she came back to you afterwards. You probably couldn't find those charts. Yep. Go ahead, please.
Yep. So that's there. So if you look at probing depths, still the prognosis of those upper anteriors, and that's been a major problem. That's the cause of her aesthetic concerns, mobility, etc. Posteriors you can stabilize. Obviously you've got tilting around there, loss of the 6s, tilting. It's mainly what are we going to do with those upper anteriors? From a cosmetic point of view, if we go back to the photos, can I have a look at the photos? What do you do with the 1-1 from an aesthetic point of view? Look at the actual gingival margins on that, position of that. Can that be brought down? Would you retain the 2 central incisors?
I would retain those 2 centimeter incisors. Interesting. I'm going to, Julian, right, teletext, could you please explain the use of patient mirror that shares parameters and how lateral excursive movements that contributing that needs to be adjusted? Okay, well, Julian, I want to ask you a question. Is this a primary occlusal trauma or is it a secondary occlusal trauma? Someone's going to answer this question for me, and why?
Hi, Sarkis.
Secondary.
Go ahead.
Secondary occlusal trauma.
Okay, Julian, what do you think? Thank
Probably
you.
secondary. Like, I think the fact that it's gotten worse over time probably contributed to from the perio. That would be more of a secondary cause, I would think.
Yes. That's right. It's secondary occlusal trauma. So how would you test the parameters here? What do?
Well, you'd check the occlusal, pathway and see if any lateral or protrusive movements would cause the movement of that 1-1. And also, check for any pain with any TTP or pressure test or anything like that.
What sort of pressure test would you carry out, Julian?
Well, just TTP with the back of my mirror head, or even just movement with, digits, like literally checking that tooth itself.
That's right. Simple one, just put your finger there, give it a bite. That's all you need to do. Put the paper in and pull, you know where you are. Okay, so it's a secondary occlusal trauma. Okay, what's a primary occlusal trauma? Thank you, Natasha. What's a primary occlusal trauma?
Is that just from the periodontium will be healthy, but the occlusion, there's something wrong with the occlusion?
Absolutely, absolutely. As a matter of fact, primary
You
occlusion.
said you're not going to ask me questions today.
Well, you answered. I'm happy to ask you. Primary occlusal trauma is actually histological. You can tell there's a widening of periodontal membrane, and it's caused by usually either dental filling, could be, or some other ways that we contribute to primary occlusal trauma. Now, there's a question from Cheyenne regarding would you suspect history of a NAG with this presentation? If so, would you recommend any specific periodontal therapy regimen? Okay, Stan, did you do any azithromycin prescription for this patient?
In this particular case, no, because
No, I saw her initially debrided, recharted. We had improvement. I then referred her to you for the occlusal equilibration to try and remove the. I haven't seen the patient since then. Oh, well, she'll be coming back to you soon. But we'll show you the case as we progress. So the treatment planning for this is occlusal equilibration with periodontal treatment, because if you got traumatic occlusion and you got periodontal, bone loss, it accelerates the bone loss. And in many ways, having 1-1 and 4-1 in parameters, it's accelerate the bone loss here and also bone loss around 4-1, because you can't plaque while occlusal trauma is. You have a secondary occlusal trauma with rapid, deep infrabony formation and eventually loss of, papilla and recession as to the type 3 and 4 type of Miller's classification recession. So I'm not sure if you shared a NAG in the past. I think it's basically because of the crowding, but nevertheless, Stan, this is your X-rays. I'm sorry that I had to magnify them, but I see a problem here, and on the OPG, you probably see that as well. But I see a problem here, and what I normally find that patients with large skeletal discrepancy, which is a high angle biprotrusive case, and when the apex of the tooth is close to the surface and you take a PA, you think there's a periapical error, but that's actually a vital tooth. And time will tell. Here's a lower, you can see how much bone loss, bone support we have here. Stan, would you like to comment on this, please?
Well, that's it. If you look at, sorry about the posteriors, but it's mainly around those anteriors, right? The amount of bone loss. Molars, not too bad. All right, you've lost about half on the lower incisors. So the area that we need to sort of concentrate We've gone in there. This was prior to debridement. There are still deposits there. Do you have any further X-rays?
Yeah, I do. I'll come back to it in a minute. This is so Stan, this is 17/7. So I'm seeing the patient. I got one after almost 10 months later. This is the perio chart 10 months later.
Yep.
And this is about the time we're going to do perio stabilized, and then we decide that the bleeding is almost reduction. You still have your mobility, you know, around about 2 on the lowers, and you got 1, 1, 2 on set. So that's still been happening, but overall mobility is, I'm sorry, 1, 1, 1. So it's reduction mobility here, and I think overall the patient has been improving hygiene. She's regularly visiting Dr. Howard's room, and also comes to our room. So we maintain patient, and there's a reduction in bleeding. So at the time we thought that it would be ideal to think about doing orthodontics. So that's the stage we have.
What do you say? Can we just go back to that charting?
Sure.
Look at the 8, right? You've still got 7, 8. You've still got 5s and 6s around that area.
Yeah.
What are you happy to progress from there?
Well, put it this way, we basically at the moment we reduced these scores a bit, and I was under pressure seeing you, but
I haven't seen them since 19.
19. Well, at the moment when we did the perio chart for this patient,
when was this chart done?
28, the 2nd, the 5th, right on top.
Right. Okay. So we've still got 5s and 6s around.
No 5s and 6s, but there's a lot of reduction, and she's working very hard on it. But my concern was at this stage is that if I think this is what happens, Stan, is the fact that she had to go to a wedding, and the deal was we can get her close to that stage for her wedding so she can look good. That was the deal. And that's why we start ortho. But you know, she's really improved up to this point. You have to accept that it's improved to some degree. And so that was the stage. And what we thought that if we can at least improve the upper arch, because that's not much of an ortho to be on the upper arch, it's quite correction. So if you can just improve the upper arch and get those teeth lined up nicely, it will help it to also improve the gum. And if you can do also improve the lower arch, it will also help us in terms of, you know, improving the oral hygiene. Now, this is the OPG that we had when the patient first presented in the practice. This is like the OPG when we first had it, okay? First time, that's the charting over there. That's a different charting over there. But that's the first time with the OPG on 15/7. And you can see here the level of bone. You can see some capillary remaining. You can see the extent of bone loss here. So would you like to comment on that step?
So this was after the debridement. When did on the 15th?
No, this is before. This is Dr. Howard's OPG sent to me. This is before I referred you. I thought I'd bring that up here.
Yep. So following that, there was a course of debridement that we went through.
That's right.
We've had improvement, but we're still, as I said, there were no changes in the bone levels. Would you expect, even after debridement, to get any bone changes?
I would expect, after I get bone changes, I would expect also with the equilibration, the redistributed forces here. But a lot depends on the patient. She stopped smoking, obviously, and she's changed her health, and she's very motivated. We've seen the patient change her attitude quite a bit. But we, you know, if you look over carefully, we have infrabony, or I don't know if it's pseudo pockets here or infrabony pockets here. I mean, they're there. So, you know, there's a pocket here, so there's a capillus remaining, so that has to be debrided. So, but the bleeding probably has improved immensely. But nevertheless, we have a difficult situation, and my aim is to get healing on the upper anteriors as much as possible. and to improve the oral hygiene. So I'm just going to show the case just to give you the full picture what we're seeing. This is before you have treated the patients then. Okay, this is before the trip.
Yep.
Okay. But as you can see, the extent of, you know, this is some image I like to take when I'm looking at patients overall treatment planning, and naturally the name of the game is your resolution. You can see the difficulty we face, the aesthetic defect that would be created if you lose those teeth, because you get this big, like a reverse cerulean appearance of a bone loss, which is very hard to fix, extremely hard to fix. If you lose it with 1-1, you have a huge defect that's extremely hard to fix. So anybody would like to make a comment?
Got a very high smile line there.
Mm-hmm. It is, Isadora, it is. Did you ever, you know, you have a Biomax case, class 2 Biomax case collision. Okay. And if you do orthodontics, you have other issues. You have other issues. Okay. Anybody else like to make a comment? Can you intrude teeth? Oh, I cannot love you. It's a tough one, Ken. I think with periodontal involved teeth, you can probably tip them and maybe slightly move them, because when you apply brackets or apply forces, it has to be very, very gentle. So because your center of the movement is no longer in the middle of the tooth, actually it's way below, halfway between the root and the remaining bone. So intrusion might, in this case, and I'll show you the images, that's a good question to ask at this time, Khan, and thank you very much for that. And so the question I want to say is, what, if we did orthodontics, what would be my most important thing? Let's assume that standard the periodontal treatment, and we got resolution, we got some stability. I mean, what is it about patients who have age 35 have advanced periodontal bone loss? I mean, what am I thinking in terms of overall management? Okay, let me give you some hint. Okay, is she prone to further periodontal disease if you control the plaque, if you control the bone level and stop them from progressing? You think we'll be able to stop them, and this will be a continuous process for the rest of their life? Can someone comment on that? I'm talking about risk assessment for further periodontal bone loss, knowing that she's age of 35. I'm going to pick a patient. I'm going to pick a colleague.
Have we established a cause for the periodontal disease?
Yes, we did. Okay. The cause was poor hygiene. Okay, and smoking. Okay, and secondary cloisal trauma that excited the periodontal disease.
So can we assume that we should be able to control, have we ceased smoking?
Well, if you assume you can control it, yes. But my question is, after you control it, are you assuming that you fixed it up, or there's a continual risk that things will reoccur?
I mean, there's always a risk unless they're regular attenders, unless they absolutely stop smoking. Yes. We could have relapse.
Let me tell you, even, okay, even if they stop smoking, the risk is always there. She's a high risk for periodontal disease and progression. Okay, minimal plaque is a high risk to cause further bone loss for her. She has to maintain religiously. Even some of the cases of maintain religiously end up losing teeth anyway. I mean, Stan, would you comment on that?
My concern here is if you look at it across the upper anteriors, right? The area that you look at immediately is between the 1-2 and the 1-1, right?
Right.
Why have you lost the interdental papilla to that extent? What's different between that and the 2-1-2-2? Why didn't it occur on that side? In other words, there is a site-specific difference in that area there.
Exactly. What will be the reason? That's a good question. I answered part of it. Hopefully hopefully the participants can actually come back to that. So, Izzy, why don't you answer that question? What was the specific situation where there's a loss of more of a bone?
How is that different to anywhere else, right? Why didn't it occur between the 2-1-2-2?
The occlusion, the occlusal forces from the lower teeth in that area specifically, possibly.
Yes, but can you be more specific, Izzy? More specific?
That anteriorly displaced 3-2-1, 4-1, 4-1. The force from 4-1, is that acting directly against 1-1-1-2?
Absolutely, yes. It's traumatic occlusion and plaque that gives you advanced bone loss. Okay. And
Do you have an occlusal view, Sarkis?
Yes.
Can I have a look at that and show them? Look at the position there. What's happened?
Do an open contact, Sam.
Open contact, but that tooth has drifted almost out of the bone in that particular. With inflammation, if you lose the bone there, you're just going to lose the tissue as well. If you look at the opposite side, that's sort of guarded and protected. That has drifted, and the further that drifting, the more recession you're going to get between the 1-2, 1-1.
Okay.
Do you agree with that? Does everyone agree with?
I agree with that. Okay, your Choi Lee is a local factor, poor control, restoration causing plaque retention. Okay, it's possible. I think occlusal trauma has got a lot to do with this, stand to open eye contact, and also poor restoration could contribute to that. And eventually the whole thing opens up, and we have a, synergy of multiple factors. Okay. Let's say we've controlled plaque. Let's say we've controlled a lot of things, and we now want to do something special after we promised she has to go to a wedding. That's what actually caused her to come in, because she has to go to a wedding. There's a wedding coming up, and she can't look like this. So if you had to do orthodontics, what sort of images would it take to have a more assessment of? Anyone? What images would you need to see before you do orthodontic treatment? Assuming that you've controlled the plaque, controlled the inflammation, and controlled your occlusion, you redistribute forces, what would you like to see?
Lateral set.
All right. That's it. What else? Will lateral set give you good information? We have lateral set, by the way. I mean, Dr. Howard's taken lateral set. But before she did, I will have a bit more information before I was comfortable. Let me have it. Let me see. Nitin, please go ahead. Can you hear me? Are you there, Nitin?
Maybe a CBCT and airway assessment.
Okay. All right. Let's not worry about airway. Let's see what would say. That's a good answer. CBCT. What would you need to know in CBCT? I want you to look at this picture here and that picture there. Should help you out. Or that one here and that one here. That's what I like to see when you're doing case presentations. You want to see retracted views and a smile. That's how she bites. You know, it gives you the full information except the closure views, but generally information is there. So what will CBCT show you?
Root positions in the maxilla
Okay, just the maxilla. What about mandible?
and mandible, yeah, and mandible.
Okay, all right. Look, I wouldn't know what to expect, but let's go next slide. Okay. Can you see we have a problem here? Can you see that? Look at the level of bone loss everywhere. And there's a cross section. This is 4-3, very thin labial cortical bone. This is 4-4. Okay, very thin. There's almost pseudopolyp formation. This is 4-1. I didn't mark it. That's 4-1. Okay, this is the front tooth here. And this is 3-3. I mean, there's basically very minimal cortical bone. You can't see it. Hardly the bone. So, Ravi, if you had to intrude this teeth, we might have a problem. But fair enough. So, how would you consider moving teeth in this patient? I think Archana Bali talked about, can orthodontic treatment be considered? When we talk about orthodontic treatment, yes, that's what we're looking at. We need to do some sort of improvement so this patient doesn't feel like we're proud of the teeth, they start liking the teeth. So from a psychological point, we need to move things around just to give us some hope. That's very important. We don't want to lose teeth, but what would your trip, Izzy, what would you do for this patient? If you had to move teeth around, what would you do?
I'd be very concerned about pulling those teeth out of the bone structure. I guess you would move very slowly.
Very slowly, very light forces. Okay.
Would you consider any extractions?
Yeah, easy. Would you consider extractions? I'm going to get Dr. Howard here soon.
I think you'd have to do a space analysis, but likely, unless you
The
can
last thing you
have
want to
the-
do is any labial, talk those teeth labially, because they're already just about out of the bone, right?
Yeah.
To create space, you either extract or you move those teeth labially to get a larger arch. Do you agree with that?
I agree.
We've got space. There's space distal to the 5s. We could
Yeah.
distalize.
Mm-hmm. Okay. You see, I think differently. I would say I want to get here as quickly as I can, have a minimal torque on the teeth, because when you have periodontal bone loss, teeth with minimal roots inside the bone, they can move quite fast, but you can also lose a lot of the labial cortical bone. So in many ways, you will want to intrude those teeth, which I think will cause more problems than ever. But you want to sort of move those teeth as close as you can. Okay, Dr. Howard, would you come on board, please?
I'm here, sir.
Right. Now, Dr. Howard, I recommended that we remove tooth number 4-1, if you remember.
I do.
Okay, but you don't have time to make space 4-1. It actually causing more problems than ever. So the reason we remove 4-1, because that will give you room to play with the 1-1, putting the arch nicely, correct, in a way.
That's right.
And then you'll be able to redistribute those teeth with given space, correct?
Yes.
Okay. Now, to help you along, we did a procedure called PAOO, correct? This is about tissue piezo surgery.
Yes.
Right. Okay. Now, I'm going
On
to
the
say
day that we put the braces on.
that's right. So we did piezo surgery on both arches with the braces on, okay, and you know, with the improvement hygiene, you can see gums are better already, okay, all right, and we're starting to. I'm just going to get out of this section. So if you know about this, I just want to get on with it. That's initial presentation. All right, Stan finishes his case. So Stan the patient comes back from Dr. Bayat, says, look at the gum health improved. Okay. And I'm looking at different ends. So we have an improvement, Stan, in a level of hygiene. And she's really cleaned those teeth. You can see there's really improvement. Okay.
But look at the recession now on the
We're
distal of
losing
that
audio,
one.
Dr. Sarkis.
Yeah, I can. I've got no choice then.
I'm
What are we
agreeing.
going to do? So we maintain her. Okay, we maintain her. Dr. Howard, we took that 4-1 out. Dr. Howard, go ahead, please. So upper arch, we improved immediately. It took 2 months, right, Dr. Howard? Christina? Or before she comes back. So upper arch, it took 2 months to level line. It's got pelvic retention. And trauma is reduced on 1-1. There's absolutely no contact. And Christina, if you're there, please come in. And still some plaque here, you can see. So she's on a vigorous control of those plaque. She comes regularly every month. We just clean. That's what we did for her. Okay. So in many ways, that's giving her a nice resolution. I mean, we have adjusted a little bit here, brought those contacts in, adjusted, we brought those contacts in. We haven't really replaced those composites. Just polished them and made some room. And we sort of improving the contact here. It's longer contact than it used to be. So it's reduced the dark spaces here. It's sort of tissue management here. I mean, so I'm not going to be comfortable with any tissue grafting here. It might get worse. How do you feel about tissue grafting here, Stan?
Not in that. How do you close a black hole? I've got no bone. I've got nothing. If it was on the labial surface, you can graft. I can bring it down.
This is
actually
for free. Yeah.
It's not predictable.
Yeah. I think Christina's gone for some reason, but I hope she was here.
I'm here.
Well, you're supposed to come in the conversation, Christina.
I'm here.
This is your
I'm
work we're
listening to
talking
you.
about.
Absolutely. I was admiring it, as a matter of fact.
It's a bloody good job. I mean, you should say it's just 2 months, and she was so happy, this patient. And in more or less, Stan, would you agree that gums actually started getting better here?
Yes. Yeah, I'm not arguing about that. I'm just looking. So when she smiles, is she happy with that result now between the 1-1, 1-2?
Well, put it this way.
No.
Now, what's her comments?
She hasn't got a choice, bro. Stan, she hasn't got a choice. But we're going to fix that later on, restoratively. Okay? But at the moment, she's very, very happy because once we removed the brackets and we put down, we immediately went and did some restorative work, and I'll show you in a minute. So Dr. Howe, you want to comment further here?
My comment was having to remove the 2 gold onlays or inlays that were there.
Yeah.
Was one of the hardest things. Have you got it out yet, Dr. Howard? No, it took me a long time because it was actually pinned into the structure in a way I've never seen before.
Exactly.
So that was an interesting part.
We had to surgically extract it, didn't we?
Yes.
But what I'm talking about to my colleagues is about teamwork, okay? How we sort of work together. So you know, you might say, oh, the premolars not idealized. I could have expanded. Guys, we haven't got time for that. I want to rotate those teeth so I can improve the oral hygiene and maintain what we have, because the actual position of the teeth now is contributing to more bone loss. So having stabilized it took 2 months. We knew it would take 2 months. And then we show light forces, it worked very well, and to split it. So I'm not really worried about this premolar being inside. It doesn't bother.
That was an 012 night eye.
Night eye. That's right. So let me just show you this. This is your lateral calf, and this is the patient basically I did some composite work at the time when we finished, and that's before. She actually hasn't seen the teeth at the time, and you can see how just doing some restorative outcome. I'll show you, you're still doing lower orthodontics. So we go from here to there. Okay, I think standard patient's eyes tell me that she's happy.
Yes.
All right, and this is Dr. Howard working on her in my practice. She visits every second Friday. We actually did adjust every second Friday with light forces. And obviously she's very, very happy here. She still hasn't seen a lot of things, but more or less, I'm going to show you the video here. She's looking at the case. We've done some composite work, but she doesn't see her case yet. She can't see in the mirror, doesn't know what she looks like. Okay, we just done some work on her. For a wedding.
And you give us how many months? 2 or 3. Yeah. Let's just look at this one.
I'm just going to show you this. I'm sorry, we don't know how long they're going to last. We never promised that to a patient. Okay, now, we're talking at initial presentation, and we're talking about mandible. Went from here, reassessed, hair treatment, Dr. Boyardzi's asked, gums getting better, test the system. Okay, post orthodontics, 4 ones missing. And look at the gum health. Okay, we can't do bone grafting for gingival architecture. It might make it worse. We have to wait. This is a type, almost type 3 to type 4 Miller's defect. It's just very, very hard to do. I wouldn't be
The lower arch wasn't an aesthetic problem. If you look at her when she smiles, you can't see those spaces.
Stan, I'm afraid that was an aesthetic problem. I'll show you in a minute. You'll see it. It's actually a bigger aesthetic problem than the upper arch.
The lower?
Yeah, we dentists tend to think about the upper arch, and I will prove the case very interestingly. I'll show you. That's going to be a bigger problem as time goes by. Actually, I'm writing an article for this because it's really important to understand the lower arch. People tend to ignore it. Now, when we look further on, okay, she's been maintaining. So if you look up from here, from top, the lower arch and the bottom, it's quite obvious that we have achieved a gum health. Would you agree with that, Stan?
Yeah, I'm not arguing.
Okay, so what we also did was the most important part, keep testing a system. She has to stay within the program, in the maintenance review. She'll come and see this one. So we're looking at 1 year post-op. Okay, we achieved gum stability. But the problem is now we have corrected level aligned the teeth. Okay, and we asked her to smile. You see how low it drops? Any comments on this from the crowd? So it wasn't a aesthetic problem. She kept on trying to hide her smile. But when we're doing dentistry, if you don't pay attention to this, if you fix everything else, this will be an eyesore. So we need to address this issue. Now, how would you address this issue now? You got lots of gum. We can't regenerate those gums, can we, Steph?
Not in spaces like that, you can't, no. There's nothing to put the gum and to hold it into that position. You need some.
Exactly. Any takers, how would you restore this? Come on, you restorative gurus. You're going to say something to me, please. I'm waiting. Nimesh, go ahead.
Yeah. Well, of course, I want to play with the composite there and just at least minimize those black triangles, but just enough for her to maintain the hygiene. I still want her to use the pick stays or water pick in there, but just maybe I'll try
it's simple,
with the,
isn't it? See how we simplify it? So it's simple now, isn't it?
yeah, I mean, we can play with the composite, or of course, when you are doing the ortho, we could have just slenderized or IPR those teeth just to get the parallel contact. So that was another
contact point.
Yeah, and just get the contact point a little bit more broader.
Why would
I think we did. I did do that, and that was probably as much as you could get, because
okay.
I was again. I mean, why do you think, Nimesh, we wouldn't do that? Seriously, let's say we could, but we decided not to because we have plenty of room. Why do you think we didn't do it?
So beautiful.
Huh? Why didn't
we did? Well, I mean, I was just sharing. We could have done it.
Understand, but yeah. Understand. We want ideal treatment, but you see, I'm trying to make everybody understand. Okay, it's very good to see, but where were we before?
And it was very fast.
Where were we before? We were here.
Yeah.
We go from here to there.
Yes.
Okay? Now, when I go to this position, I say, Krishna, stop. Why?
Because you're risking then perforating the bone.
You're risking a more bonus. I can't afford it. I can't afford a bonus. I don't give a two hoots about any proximal issues. I don't have a problem with that. But we are trying to maintain biology here. Because without bone, I don't care how good it is, tips in the gut. You see the point?
How far did you advance them, Christine? Those lower anteriors?
I didn't advance them.
We tipped them.
I just maintained them where they were.
Exactly. And we did PA00.
And even if more, just a little bit of retraction more than anything else. Because I did have the space of 4-1. I had the space when we first extracted it. There was probably 2 millimeters there to play with.
So is there anybody disagrees with this treatment, or are you happy so far? Can I go next slide?
Very happy. Let's go.
Okay. Thank you, Nimesh. Okay. Next slide. This is before. This is after. We use thing called pink composites here, Stan.
Yeah.
That's the only time we use pink composites. She got smile more, but she's more confident. We try to make her smile a bit more. Look on the side. Here's the side. Same patient. I know those anterior torticollis got guarded prognosis, but I'll keep extending the life of this guarded prognosis as long as possible. Just because it says this guarded prognosis doesn't mean you're going to go and take the teeth out. I mean, what's the next option? So it's important to understand, different patient. Here's some pink composites here. Okay, it may not look attractive because she's on a cigarette. It doesn't matter. We also put some composites here on the bottom, but it does the job for me for a time being. It's not the best composites, but I don't mind. I don't have a problem. Okay, at least I know this patient's confident. Not only confidence, but she smiles, right? You have to get a scalpel and you just clean this excess out. So some excess that we remove. Okay, we clean them out. Okay, we improve, create some nice, we teach you all that at the college, how to create nice translucency. It's not rocket science. You'll be doing a lot of hands-on techniques in the college. I said, people ask me, is there a lot of hands-on? Yes. But why don't you ask me, is there more in terms of how to think a case, how to build up the case? There's a lot more of that as well. Okay. So she's happy. You got a good gut response. As time goes on, there's a chewing gum in the mouth here. And, composites, unfortunately, does break because we have to constantly repair them in this particular case because she's basically got a big diet, a lot of issues. But nevertheless, we maintain this patient. This is 2 years. She's in function. And she came the other day. I saw we had a bit of a clean and we did painful charting. And when you look at 2.5 years of journey as of yesterday, we started from here. We went there. Okay, we went there. Here's your lower lip. You can see now. Stan, this is for you, Stan. See how low the lower lip drops. That's normal. So Bimax, okay. Bimax will be high angle VME, okay. And when she smiles, the whole lip retracts. So the lower aesthetics is crucial. As a matter of fact.
So why weren't you seeing that initially when she was smiling?
Because she didn't want to show all. People normally
showing. She wouldn't.
Smile.
A guarded smile.
It's part of the. See, I make people smile in the way I tell them to smile because I can pick up everything, and I knew this was happening. This is why I wasn't. I want Dr. Howard to finish his case as quickly as possible. Okay, quickly as possible, and we level line those arches, and we constantly clean those areas. I mean, this I thought was the best way to go to give her every chance for the upper anteriors and lower anteriors to maintain personal health and create even gum architecture. That was the other.
So what was the time span of the ortho from start?
6 months on the lower and 2 months on the upper. Yeah, is that right, Christina? Is that?
Yes.
Yeah, start with PA00, we cut everything in 50, cut in half, treatment's cut in half. I mean, I do a lot of cases, Dr. Howard. I do a lot of PAs. We move extremely fast. And again, here's the lower arch. Here's your,
Someone asked about the fixed lower retainer.
Yeah, it's there. It's there. It's not there. It'll be there. I took this photo before you placed it.
Yes.
Okay. Well, it's not just that. And patients regularly coming in. And, we really think that, I can do better composite than I did this. I can make this patient look glamorous now because we've got everything in the right place. I know they've got a prognosis. I know. What was the most important thing here in this case is maintain the most essential elements. That's for biology. I can fix teeth as long as we've got the bone, as we've got support. So even though we have 5 mm support on those upper anterior 4 teeth, at least I know that that's good enough to maintain function, comfort, and aesthetics. So which is a better option? Taking 4 teeth out and placing implants, there's just not enough rooms, okay? And it's a high risk of further bone loss, further problems occurring around the implants. With a high smile line, okay, with angled upper and lower jaws, with a sort of bell-shaped type of bone support that disappears by the time you get there. I mean, this is a high risk for implant surgery, high risk for implant maintenance, high aesthetic risk. Everything you can think of in the book of dentistry is highest risk for this patient. But we've maintained what we have by understanding the preservation of biology. You see, what I talk about goes completely against the law of the establishment in terms of what people expect to see in doing some fancy implant surgery, prosthetic work, or some fancy crown bridge work, where simple but effective treatments can do the job immensely well with minimal outlay of cost. We forgot the cost, not the foundational cost, but biology cost. And also financially, It was minimal cost to this patient. I think this patient cost what, less than 10 grand to fix it. Okay, less than 10 grand. I mean, you think about this case, okay? Is the patient more relaxed, happy, understands? So we're coming back to the X-ray. So when you think about this is an angle. We haven't lost roots there. This is angled, okay? It's tipped slightly forward. That's what we're seeing here. I'll go to the CT scan and put up. So I can tell you one thing, if I align better, okay, I've got a bit of overhang here. I'm very sorry that was removed. We did that yesterday. But something here you can see that there's no periapical area here at all, and the tube is still white. So what happened? They actually did a CAT scan, the trough, the actual trough went all around in a different angle, or we got some sort of healing. I think we have a healing here. We also have a good qualifications. Then you can see that here all around. You can see cortical bone. That signifies mere stability. There's no rugged appearance. And look at the lower arch, it signifies stability. There's no rugged appearance. Okay, maybe this one's loading. I need to look at the bite. But overall, this patient is very diligent. So let's go back to the charts. Stan, this is your chart. We're going here, right across.
Yep.
And you want to comment on that?
Dr. Sarkis, there are two comments.
Go ahead.
If I'm looking at first.
Fixed lower retainer do not need a pair of maintenance? Absolutely not. Fixed lower lingual retainer, upper retainer. It's fixed upper and lower. Here's your X-ray. Here's your X-ray. Here's your X-ray.
They're V-loop retainers, yeah.
Yeah, that's not an issue. You can easily clean that. Not an issue.
It's positioned such that you can still get a proxer brush underneath. A little
That's
pick
right.
up.
You can easily get it. You can easily get it. So we removed, we fixed the disaster. At least we halted for the time being. So in your opinion, how long can we maintain this situation? Anybody, how long do you think we can maintain the situation?
10 years.
As long as possible, and as long as it's needed, keep going. Because
I want, it's very close. I want a bit more different answer, but very close, all of you. You forgot something very important.
How long is a piece of string?
What's the most important thing in here? Could you explain why you didn't mistake for the pathology 1, 2, other than pulp testing?
Maintenance.
Ah, very interesting. Well, it was vital. Okay, it was vital. Does every periapical lesion relate to pulpal, or it could be related to periodontal lesion? How do we know? Just give you a tip for half a chance.
Test for fremitus.
Give you half a chance. I mean, the other thing is that what I would want you to say is like, we can maintain those teeth as long as the patient keeps their SPT support therapy, stops smoking, maintains their regular visits, is diligent in home care. So the answer is, if she wants to maintain it, we can maintain it. Does it make sense? So it is the patient's problem that she needs to own. Otherwise, it becomes whose problem?
ours if she doesn't.
Whose problem will it be for the patient's problem? Guys, I need an answer.
Yours, Dr. Sarkis.
That's right. And yours.
Oh, no, I'm gone.
Let's look at some charts. We can measure, we can manage it. This is Dr. Stan's chart. This is the chart when we started. This is yesterday. Now, Christy, my oral health therapist, did a chart. He said, look, Dr. Sarkis, I don't believe this is, but it is what the reading shows, okay? It's what the reading shows, okay? This is our reduced mobility, still 111, okay? On the lower. So I got two uppers, I apologize. I got two uppers, I made a mistake, okay? But there's reduction of bleeding. Maybe it's a low one, huh? Let me see, maybe go next one. Sorry, it's a lower. Yeah, it's a lower, sorry, okay? And you can see here, there's a mobility of 111, okay, and reduction of bleeding. You know, so we have at the time being stability. You know, stability, and Stan, she needs to come and see you.
Yep.
So what am I talking about? Why we need to continue this? Because is that you need to continuously test the system, because the risk is always there. With patients that have higher risk for periodontal disease, it never disappears. They constantly need the SPT to maintain what you've tried to regain, which is bone stability. Okay? They never should be regarded as a stable position, never stable. Okay, they should. Is that right? Would you agree with that, Stan?
Yeah. Yep.
So, this is your lower arch, 2.5 years. And I'm going to play this video for you before I finish this case. And if you don't hear it, I want you to hear it. The patient has not seen the case. This is when we finish the upper arch, not the lower arch. I'm being cheeky, I'm sorry. You can see lower braces still on. She hasn't seen it too, so. There's a father, parents out there.
Well, you know, she didn't learn some of it. I just didn't get it.
Excuse me, Dr. Sarkis, did you have my consent for that?
No, I don't care.
It's a piece of drama, huh?
Real drama. So we talked about the management. We talked about.
Is this available on YouTube?
Yeah, you want it? I can send it. I will. Okay, we need to plan for results, not for procedures. And that's what I'm talking about. Okay, you got to understand what is your end point, how to look at the case. See, now this is what we teach at the college. You can do all your 2-day piecemeal courses where you want to do it. At the end of the day, you won't be able to connect. That's why you need the college to help you to connect them. And that's what we do. Most of the time, it's exactly what we do, because trying to help you to do your cases as predictably as you can while preserving and giving biology a chance to help you. Any questions? No question? No one?
No, beautiful service to the patient. She would be so grateful.
She's very lovely. And this is the last part of the periodontal lectures. We have an endodontist, Dr. Garim, will be talking to us about endodontics, and we have another specialist coming up 2 weeks after that at the endodontic sections, and then we'll talk about some other multidisciplinary treatment for patients. But you can see how important was the general dentist's role. Dr. Christina Howes, in this case, got large orthodontic experience in coming in at the right time, getting those teeth in the right position for me. And I mean, she could have done those composites, but at the time she said, well, would you mind doing it for me? Because your patient's here. Let's see if we can fix the problem. Now, there's no reason why Dr. Howard couldn't do those composites. That's, you know, it's no brainer. But it just happened at the time I ended up doing it. But I couldn't see, you know, whatever it is, it doesn't matter. Okay. At the end of the day, this patient went from A to B. This patient looks, you know, I think fantastic. You know, and could I envisage this happening? Well, after about 12 months, I said, yes, we could. So we did therapeutic diagnosis. You clean, recess, home care, patient response, patient compliance, and you build up rapport. Patient feels comfortable, they're hooked, they want to do the job. You understand? So you got to get those patients comfortable. It's what you say and how you say is critical in your patient outcome. Don't be carpenters, don't be mechanical. You got a real biology, live and well biology in front of you. That's trying to explain to you, you know, please help me out. So listening to the patients is very, very important. The rest, composite veneers, it's mechanical, not an issue. I just want to get that message across. So having said that, just remember that we got courses coming up, and those of you who want to ask me any questions should consider at least coming to the courses and learning how to make pasta.
There's a question, Sarkis. Someone just asked about PAOO.
Yep. PAOO.
What is it?
It's a periodontal system. It's excellent orthodontics. I need to discuss that in a piezosurgery course. And if you're doing orthodontics, this is your #1 armamentarium to make things faster. I do orthodontics as well. I work with Derek as well, with Derek Mahoney. I was a good colleague of mine. This is the wrong dates, by the way, so it's not finished. I won't be here. I've been at Tango Festival in Tasmania. But we got the dates coming up for those soon. But we're going to talk about the incorporation of this, how to think and how to apply. In other words, even when I'm doing implant surgery, I'm doing bones. This is all my images. There's not taken images from some company. So, you know, how to section a tooth, how to take it out, how to create pieces, osteotomy on this side using piezosurgery. I mean, you see also tricks in the trade, but this is so simple. How to split the ridge, how to do complex, implant placement, how to place the implant in the septum immediately. So all these are part of the. So PAOO is doing piezosurgery, creating a RAP phenomenon, which is rapid accelerated phenomenon that creates a local inflammation. So during the healing process, the whole alveolar process is fluid, so that things move really, really fast. And that's the reason we applied in this particular patient, because we got a faster movement and didn't lose on the labial cortical bone. That was the key. That's important. There's a question.
I got a question for Stan and you both of Sarkis.
Yeah.
When we have a periodontal issue like this and we see that things are improving after 4 months, 6 months, and patient wants to get that confidence back, would you do the aesthetic part a bit more quicker in order to give them a confidence to look after their teeth?
Well, we did in this case. I mean, put it this way, just to get those teeth straight, and quick composites did the job very well. I went back and revisited those composites later on. But I mean, it's part, as long as it's not hindering the hygiene exercise, it's not hindering the patient home care maintenance. That makes sense? But you shouldn't jump so quickly on big cases. But in a way, sometimes if the patient is really serious about it, you can see immense improvement. Okay, you can phase that and trip it into it. But they have to understand that the time and the money they're paying, the risk is always there. They're going to sign up for it.
Sorry, Sarkis, you need to stabilize the periodontium before.
Yeah, I mean, that's no question. Yeah. There's no question. You have to stabilize. Just because it's improving, you got to stabilize. You want to get cortication. So in this particular patient, after 1 year, we started treatment. But the trouble was, on the upper arch, we had to move a little bit faster. That's the problem, because she had to go to a wedding. And in that case, Christina, we didn't really want to move any other teeth. We just moved those front teeth just to get them lined up. But again, under vigorous care, we did explain to her that, we're doing this, we might lose 1-1, okay, which I didn't want to. But look, a lot of care, a lot of thinking has gone behind this case to get it right. And we did. I mean, once you reduce the trauma, the fragmentous, things really recover very fast and the patient stops smoking more. Yep.
And it's also with the bonded retainers help it a lot too.
Yeah, they do. I think also the fact that when you see calculus and patients smoke, when they stop smoking, you got calculus, you remove it, patients go home care is a big improvement. There's no question about it. You know, and she's healthy. So that's something that we talked about. So this is courses coming up. We have the, you know, when we just use porcelain, you can see the composite. We discussed in this case, that's a full day online. And I think there's a few more here. Yeah. Well, that's doing, again, problem-solving composites using a fiber on the bridges and how to fix all these cases, how to fix the trauma cases. And patient comes in full mouth reconstructive work, the stable periodontium, and using composites to improve their extended life of the existing bridge work. And we got other case studies. This is really, really good for any dentist who wants to just improve their hands-on experience in doing fiber bonded bridges and doing composites. Look, if it wasn't for the composite, I think the arts of dentistry would have fallen a long time ago. I think composite has saved dentistry. You know, now we're looking at regenerative medicine, which is all regenerative tissues. And again, this is all composite. Did in one visit for this patient. That's a composite. That's in one visit, 2 or 4 cases. So a lot of these patients do need help. And there's so many of them. I'm seeing a lot more cases now that have been unnecessarily teeth ground and patients coming in. You knew that it could be simpler treatment, but there is unfortunately only one way to fix a problem. And that's where problems occur. When you do the diploma, you learn many ways of approaching a problem because your idea will be challenged. Your thought pattern will be challenged. Just like Stan asked me a question, it's a pleasure that Stan has been with us, asked me a question, what would you do here and what would you do there? I'll be asking the same question, why would you be doing that and why would you be doing that? And then on your answers, I'll say, why don't you read some articles and come back to me? Please start reading and putting that process. If someone actually is guiding you. And then you rate, oh, Dr. Sarkis, I'm actually creating my own recipe because you taught me how to think. You should not giving you a recipe. Okay, I will make you think and make many of your own recipes. You can make moussaka, you can make shish kebab, anything you want, as long as it's good biology, good treatment. You can make pasta, you know, as long as it's good thinking, it's got a good sort of overall problem-solving logical pattern when you're approaching your everyday dentistry. And that's what we're trying to teach. You know, we can teach you the techniques. That's fine. That's the carpentry part. But we'll talk about biology, how to approach the case so that your carpentry will be perfect. That's what we're talking about. So I want to thank everyone. If there's any question I can answer, but I think we've covered most of them.
Thank you so much.
My pleasure.
Thank you, Stan. Thank you, Christina.
You're welcome. Good night.
Thank you, Christina. Thank you, Stan.
You're welcome.
Thank you very much.
Thank you, Izzy. You like it, I hope, huh?
Thank you, Doctor.
Thank you all. Thank you all. Thank you. We had a great day today. So everyone's really, really happy. Everyone's really happy today. Okay. If there's any inquiries, just talk to Shraddha. I'll say goodbye to you all. Stan, thanks for joining us.
Welcome.
Thank
Bye, Nemish.
I think Nimesh is just gone.
Yeah.
Thank you all. See you.
Thank
then.
you.
Thank you.
Okay.
Bye-bye. Thank you.